Thank you for this opportunity to join you today and talk about the challenges that we face with keeping ourselves upright when we stand and walk about, and how those challenges increase with situations such as Parkinson's disease, and what can be done to reduce those challenges. Quincy mentioned earlier that I had the privilege of supervising his PhD program many years ago, and it's a great pleasure to be speaking alongside Quincy today. The research that I have done on Parkinson's disease, with its focus on balance and gait, has been with many graduate students, and also in collaboration with Dr. Mandar Jog at the London Health Sciences University, and you may some of you may know Dr. Jog, as well as Dr. Faye Horak and Dr. Jay Nutt at the Oregon Health Sciences University in Portland, Oregon. So, when I was asked to speak about falls, I thought, I've got to get a positive spin on this because falling is not a particularly pleasant topic. And so I chose to entitle it, Be Safe. That's the bottom line message, and hopefully I'll offer you some advice on achieving that and reducing fall risk and improving mobility. Can everybody hear me? Yeah? Okay. Well, this talk's going to be in 4 parts. The first part here is just a few statistics on falls. The second part is going to focus on features of gait that make us prone to falling. And I think if you're familiar with those, you'll have a better appreciation of the care that must be taken to ensure our upright position when we're moving about in our environment. And then I'm going to talk about the multiple neural systems that have to come together to keep you upright when you're walking. So this is not challenging a single system like the motor system. There are many systems that work together. And then finally, to look at optimal rehab or exercise training programs to improve your balance and to reduce fall incidence. So just a quick look at some fall statistics, and this is from a rather large cohort study by Stoltz, published in the Journal of Neurology in 2004. It's difficult to find a lot of studies that actually measure the incidence or rate of falls in any population. So this was done with 489 inpatients who were seen in the neurology department. And the important statistic here is that bar in red. The 489 of neurological diseases, and those are shown along the bottom. The red bar, which shows you the highest incidence, belongs to those with Parkinson's disease. And of that, the falls that were recorded, 62% of those were found among individuals with Parkinson's disease. That's higher than individuals who suffer from syncope, who suffer from loss of sensation in the lower limbs, the PNP polyneuropathies, epilepsy, and down the line to pain at the far end of the spectrum. So falls, as I'm sure all of you appreciate, is a major issue in Parkinson's disease. This next study I selected by Ann Ashburn, published in Disability and Rehabilitation in 2008, attempted to look at where most falls occur. And it's no surprise that, as the little cartoon figures below display, most falls occur in the home, in the bedroom, and by way of tripping. And knowing that, you might want to go home and make sure that bedroom area is tidied up and trip hazards are removed and lots of caution exerted in that area. The second part of this talk I'm entitling Walking is a State of Controlled Falling in which we are always one step away from disaster. And there are a set of balance demands that I've listed below that speak to walking. And I'm going to address each one of these. The first is that 2/3 of your body mass, this large section above my belt line, represents 2/3 of my body mass, is balanced over these two spindly lower limbs. Okay. The second is that the body center of mass, which is, if you bring that all together, it's around your belly button area. It travels outside the base of support 80% of the time. We are always falling and catching ourselves. The third is that the stability of your trunk is continually challenged each time your foot falls to the ground, because there is a reactive force that's going to trickle up to the rest of the body, and each time you push off, again, a reactive force at the ground trickles up. And I'll detail that a little bit more. And the final one is the maximum toe clearance. When your foot is swinging through, the maximum toe clearance over the ground is only 2 centimeters. That's the width of the palm of my hand. So that's not much clearance in the path of obstacles. So, number one, humans are top-heavy. And this is where it all started. We made this decision a long, long time ago that we were not going to ambulate on 4 limbs. We were going to stand up. We were going to free our hands to use tools and shape things. We were going to get our head high so we could see far. But there's a cost, because our balance is now limited to the 2 feet in the ground and not 4 on the ground. In my neighborhood on my street of 10 houses, there are 2 individuals that fall at least a dozen times a day and never injure themselves. And there are another 2 individuals in 2 other homes who have fallen over the past 6 months once, and they were hospitalized. What's the difference? Age? And why do 2 of them fall multiple times a day and never injure themselves? And did I hear little? Yeah, you're right. They're little. They're a year and a half old. They're out in the sidewalk exploring. They've just learned to walk. They're always falling, but they're close to the ground. And they know how to collapse. They just collapse. Okay, so they never hurt themselves. The other 2 neighbors, one in their 70s and another in her 80s, fall. Their head's much higher. Each of them sustained an injury to the head. And so when they come down, and often as we age, we become a little more rigid with our body. And so we don't collapse when we fall. We kind of timber when we fall. And as a result of that, we place our head and often our arms at risk of injury. So the challenge of falling and injuring ourselves all started a long time ago when we chose to stand up. Here's the second. Walking is a controlled state of falling, and this is why. What's the first thing you do when you start to walk? This is a question I ask every class that I teach at the university in a course on balance. What's the first thing you do? Yes. Exactly. That's right. The first thing you do is you turn off these posterior muscles, and you might turn on your anterior muscles. And this allows you to fall forward, and then you catch yourself. And to address a point about freezing, what can be seen in freezing is a failure to turn these muscles off, or perhaps turn these muscles on to allow yourself to fall forward. So the first thing you do is you fall. And from then on, every step is a controlled series of falls. So during the course of your walking, and here I show 2 steps in the diagram by each foot, the right foot and the left foot. The red line traced through is where your center of body mass is tracking. And the thing that you should note here is that red line never, that solid red line never comes under the foot. Okay, if it never comes under the foot, you're never in balance. Okay, because you're always moving it toward one foot and then redirecting it toward the next foot and then redirecting it toward the foot after that. There is one brief period, well, 2 of them shown in the cross-hatched areas here, where you, in fact, are in balance. So during healthy adult walking on unobstructed pathways, the only time you're in balance is when the 2 feet are on the ground. And this is in 80% of one full stride cycle. That is right foot, left foot, right foot. Okay. And that amount of time, again shown in the crosshatched area, will reduce that, it will expand. You'll spend more time in double stance if you walk slower. And it will reduce if you walk faster. And it'll disappear if you run. Because in running, you never have 2 feet on the ground at the same time. It's always 1 foot. So you should be asking yourself at this point, well, if I want better balance in walking, I'll just slow down. True, you have more double stance time. However, what happens if you ride your bike slow versus riding it faster? Yeah, you become very tippy, right? You ride too slowly. So in fact, there's a benefit to walking faster that you should keep in mind. That is, you're in better balance, dynamic balance, not static. You're in better static balance when you've got 2 feet on the ground. But when you're walking, you're in better dynamic balance if you can walk faster, just as you see with riding your bicycle. The next point is that the trunk and the head stability is challenged by each step. My diagram, you should start from the bottom and look at the blue line. Every time your foot comes to the ground, and you can feel it, there is a force, ground reaction force, acting backward. Okay, and you'll really tune into it if you do that on ice, where there is no ground reaction force, because your foot will skid and you'll fall backward. So on a surface like this, there's a force. That force trickles up and creates a backward motion of the hip, which can thrust my trunk forward, but it doesn't, and I'll explain that. And when I push off, there is a forward one, a forward ground reaction force that thrusts the hips forward that would tip my trunk backward, but it doesn't, and I'll explain that. Okay, so if we exerted no corrective actions at the hip when we were walking, but the brain does, but if we didn't, we would walk like, okay, but that doesn't happen. The trunk, in fact, moves no more than 2 degrees. So it's very, very stable, which is good because you want to keep your head stable so you can see where you're going. And that is because the nervous system anticipates those destabilizing forces and sets in motion a force around the hips, which corrects it before it happens. So to the right of that diagram are lines with hills and valleys that are opposite one another. And the red one is the force of gravity that would be tipping your trunk back and forth as this reactive force comes up to the hip. But the stabilizing force, which is driven by the brain, is the one that works in the opposite and keeps your trunk in place, which is shown by the black line. So there's a lot of work that the brain's doing to keep us upright as we walk. The next point here is that toe clearance as we're swinging through is no more than 2 centimeters at maximum. And as you're coming in for a landing, it's gliding down to about 0.5 centimeter. So at the highest point, it's no higher than the width of my hand. So if I put my hand down as you were walking, and you didn't notice my hand there or an obstacle of that thickness there, your foot would come in contact with it, really falling. You didn't correct for that. So there's not a very large safety margin when we're walking. And for those of you who have lived through the construction in uptown Waterloo with the new ion system going in, or visited, I would love to see the incidents of falls that have occurred in the downtown area, been reported at the hospital for that period of time. My guess is they have spiked upward because there are so many unpredictable changes in elevation on the street. But we successfully adapt our gait to many challenges most of the time. We adapt them to winter conditions when the surfaces are slippery. We adapt to wet surfaces when it's raining. We adapt to doing 2 things at once, like texting on our phone. But not all the time. This is a picture of our former Prime Minister, Jean Chrétien, when he stepped out on a basketball court to join a group of youth playing basketball and moved a little too fast and tripped on the court. So sometimes we don't see the obstacles in our path that we must adjust to avoid tripping. That is, elevate our limbs a little higher to clear these obstacles. The gait adaptations that we usually employ when we face more obstacles in our environment are listed here. These are seen among any individual. We decrease our walking speed. So think of yourself walking on ice. It's the first thing you do. You decrease your walking speed. You decrease your step length. We take these shorter shuffling steps. We increase the double support time when 2 feet are on the ground. And we decrease the single support time when only 1 foot's on the ground. We increase our step width. We increase the time we spend monitoring each step. Usually when we're walking around, we look about 3 steps ahead for any changes in the environment. And that gives us enough time to plan, say, an increased swing height to step over an obstacle. When things become more challenging, we're doing this almost step by step by looking down. Often we use walking aids to make us more stable, canes, other devices. And so what you might note is a lot of these changes that occur in healthy gait, adult gait, with increased challenges, are those same changes that you can see if you have Parkinson's disease. You employ all these more cautious approaches to walking. That's good on the one hand, but has a cost on the other hand, which is back to this idea of riding a bicycle and being more stable when you're walking faster. And we'll get to that in rehab programs. So the third part of this, standing and walking are controlled by multiple neural systems. Standing and walking is not a problem of simply the motor system. That is the motor parts of the brain sending out signals with enough amplitude and the coordination of timing between multiple joints to keep you standing and walking. It also involves the sensory system continually monitoring our position and progress as we're walking. Okay. Our visual system, Quincy spoke a bit about that. Our vestibular system, that's our inner ear organs that judge relative to gravity, that is our head being upright and motions of the head. And our what we call proprioceptive system, which is input from muscles and joints that tell us about the orientation of our limbs relative to one another and also their movement. It also engages the cognitive system, and it engages even our emotional system. And I'm going to speak to each of these briefly. So the sensory system, we can begin with it. The sensory system is important to monitoring our state of stability, identifying obstacles in our path, and also steering us toward our goal. The motor system is important to controlling the force the muscles put out. So more force is put out, the faster I walk. Less, the slower I walk. The cognitive system controls our focus of attention, what we're being attentive to in our environment, in our movement, and also attentional sharing. Quite often we are trying to talk while we walk, text while we walk, okay, path plan while we walk. And so the cognitive system is important to moving our attention between these various tasks. And then our emotional system, it controls our mood. Your mood can affect the way you move about. I had that personal experience with that in the past 2 weeks. For 5 years, I put off a small hernia operation, and 2 weeks ago, I went for it. And for the week afterwards, my wife complained that I was looking so much older because I was walking like this. Now, part of that was the pain, but also a good part was the mood. I was not happy. This was the first surgery I'd ever had, the first time I ever went under. So I was not a happy camper. And it was reflected in my own posture, being bent over and slow movements. And it also, your emotional system also controls the level of your task-specific confidence, or how fearful you are. And that changes. I can tell you, how many people are skiers? Any? Or have skied? Okay. Well, I can tell you that if I'm on a moderate slope, I can look great. I can look really confident. Put me on something steeper and add in a few moguls, confidence level drops, fear sets in, I get a little stiff. In fact, it takes me a long time to get myself actually going down the hill. So the emotional system is engaged in the control of movement in terms of the way it will regulate the total stiffness across your body. So if we can bring these systems together into the gait changes that we see, I've listed a few here. The sensory system. Steps can be, this is in Parkinson's disease. Now, with some research we've done, and some of this is with Quincy, steps can be perceived as smaller than their actual size. So if you have shorter, more shuffling steps, yes, part of the issue could be the motor system. But part of it, too, is the perceptual system judging those shorter steps as being longer than they really are. You think you're doing the right thing. I recall, and back to my skiing example, a time when the ski instructor tried to tell everybody in the class, bend your knees, get down, okay, which is a good posture for skiing, and saying, no, it's not enough. And I look, yeah, it looked like enough to me. And then he videoed, not enough. So my perception of the extent to which I had bent my knees and ankles was not near what it truly was. I thought it was bigger, but it was really quite small. So the same judgments can be made about the length of your steps. I'm going to come back to that when I talk about some rehab programs, how you might address that. The motor system changes in Parkinson's disease include reduced force, resulting in smaller steps, weaker corrective balance reactions. So should you trip, the reactions that you take, the size and the timing of bringing that foot through to a longer stride to recover that correction is going to be slower, placing you at more risk of a fall. That can be trained, though. Impaired coordination resulting in difficulty starting, stopping, and changing directions. So you probably experience a turn is not this, but a turn may become this. Okay, so the coordination that had been there to direct turns is beginning to fade and be replaced by these small steps. Again, rehabilitation can address that. The cognitive system changes. Looking at the research, there is difficulty performing concurrent tasks, talking while walking. There's a very well-known paper in The Lancet from about 20 years ago. It's titled, Stops Talking While Walking. So if you get into a conversation where you're deeply engaged, you may find yourself taking smaller steps. You may find that you even stop. That is to preserve your balance so that you can continue the conversation. The alternative would be to shut the conversation down and keep walking. What's been reported in the literature is individuals with Parkinson's will not always make that dramatic shift. That is, they will compromise their balance. They'll try to keep the conversation going at a cost to balance. And the solution, of course, is be aware of that and monitor your balance ahead of the conversation. And then the emotional system. There is a reported increased fear of falling, resulting in increased joint stiffness. I showed you an earlier slide on the incidence of falls among Parkinson's. Alongside of that report also measured fear of falling. And individuals among all the neurological diseases, individuals with Parkinson's disease reported the highest fear of falling. Understandable, but can be addressed through rehabilitation practices. I'm going to share with you, just, how do I get this going? Oh, I'm a big Mr. Bean fan. Are you a Mr. Bean fan, or you at least know him? Have a look at Mr. Bean up here on the diving platform. All these adaptive movements because he's not confident. Well, Mr. Bean inspired some of my research many years ago, and that having been engaged in research with changes in balance and gait in individuals with Parkinson's, I at one point asked myself, what am I looking at? I'm trying to characterize the changes that are unique to Parkinson's, but I don't know if I'm looking at the disease or fear of falling. And so I thought, okay, I'm going to borrow an idea from Mr. Bean here, and I'm going to take healthy young adults, and I'm going to put them on a height, and I'm going to look at how their balance changed. So I'm going to look at them low, medium, and high heights, and I'm going to look at something very simple. I'm going to look at them standing still under various conditions of eyes open and eyes closed, or maybe 1-foot stance. And I'm going to record how much they sway. So when all of us stand, we're not really still. We're swaying a little bit. Sometimes you can see it in people, most of the time you can't. But we can record it in the lab with a force plate that we put under the feet. The motion of it, if you record it for 20 seconds or so, looks like a bunch of wet spaghetti if you dropped it down. It's moving all over. And some people will have a really tight movement and some a very wide movement. Tight's good, tighter's not too good, and broader's not good either. Okay, there's kind of an optimal range there. So we explored that and found that when we put people at heights, they get really tight, they get really stiff. And then if you move them really high, they get very unstable. Technique to look at this in a group of people with Parkinson's disease and relate that to fear of falling. I measured their fear of falling using a survey tool that was developed by Anita Myers at the University of Waterloo called the Activity-Specific Balance Scale. And this asks you a series of questions about daily activities and asks you to rate your confidence in performing them. So the teal line are a group of older adults without Parkinson's and generally healthy, and you can see they ride up close to 100%. And the pink is a group of individuals with Parkinson's disease, and their confidence levels are generally lower. And specifically, they're much lower for two activities. That is, if you ask them, how confident are you when you stand on a chair to reach? And how confident are you when walking on an icy sidewalk? So what we did in this study is we took a summary measure of fear of falling for each individual in the study, each of our individuals with Parkinson's and each of our control individuals. These are the specific questions. I'm going to just move by that so that, and the other measure we took from our Parkinson's participants was the measure of their level of symptoms, specifically those in the category of the posture and gait subcomponent, arising from a chair, standing posture, gait, and postural stability. So these are typical measures used by the neurologist. And then the question we asked is, to what extent does an individual's measure of fear of falling versus their measure of severity of disease predict their stability, that is, the area over which they're swaying? And what we find is that with the eyes open, just normal stance, here we go, the fear of falling measure in red here, the ABC, predicts 24% of the various scores among our population. And that's higher than the UPDRS score. And when you go to now stand normal with your eyes closed, your stability is predicted, 51% of the change that you now see is predicted by your perceived fear of falling, and only 5% by your disability. Of course, when you move to something very difficult, like one-legged stance, then the disorder itself takes over. So, but this is to say, especially in the middle diagram, that fear of falling is a very strong influence on your balance. So, let me get to the last part, reducing fall risk and increasing mobility. Exercise is medicine. You can change a lot of this. And there are a number of programs out there that have been introduced to help individuals with Parkinson's improve their balance control, improve their gait, and remain safer as they move about in their environment with a reduced fall risk. These include walking on treadmills at a pace faster than what you are normally comfortable with, okay, such that it's forcing longer strides, forcing a faster pace. That's been reported across a number of studies as having a lasting activity for several weeks afterwards, where people take longer strides and walk more confidently and faster. Dancing, especially tango dancing, is another approach that's shown success. Boxing, did a bit here today, and Tai Chi, these also have been, and also exaggerated movements. That's a little too exaggerated there, perhaps, Monty Python's, but exaggerating movements. You're going to hear more about this program this afternoon with the speakers who will be up here. All of these, if you think about all of those programs, they represent multi-system challenges. They are challenging not just your motor system, also your sensory system, also your cognitive system, and also your emotional system, trying to take away that fear of falling, getting to focus on the appropriate cues. This is a study fresh off the press, 2018, by a group in Europe that looked at 416 research publications on various approaches to rehabilitating, and the key thing is reducing fall risk and reducing fall incidence or rate. Okay? And they found that a multi-system balance training approach can reduce fall rate in people with Parkinson's disease by up to 60%. So that's considerable when you, in a population that is challenged by a very high incidence. I had a few slides I was going to show about some of my research on learning. But because of time, I'm going to just flip through to the last slide. But what I do want to say about this research, it's research where we gave people a very sort of novel and seemingly threatening task. We had them stand on a platform that rode back and forth, but it kept varying. And we asked the question, under something so challenging, could people with Parkinson's disease learn this task? Because there is literature out there that says individuals with Parkinson's have difficulty learning new skills. I can tell you that is not the case for balance skills. People learn very well. And it's not restricted to individuals with just moderate levels of the disease. We found that people with more severe levels, more severe symptoms, learned actually quicker because they had further to improve. They learned more quickly on this task. So some strong evidence that learning balance tasks can happen. So I'm going to get by these. And I'll just come to the end and say that the advice on reducing fall risk is to get yourself involved in these multi-system challenge rehab programs and be alert, be active, be focused, and be confident. These programs will all train you toward that end. Thank you.